A ground level fall is brought to the emergency room on a non-rebreather via emergency medical service. She has a known history of diabetes, chronic kidney disease, hypertension, hypothyroidism, and congestive heart failure. Upon initial exam, you will find that the patient has a small laceration above her right eye, but no obvious signs of skull fracture or penetrating injuries. So, what are her causes and her factors, and what puts her at risk? The fall, that's right. So the fall is the reason for hers. If y'all move on the screen, it'll move. Yeah, thank you. It'll move this. Um, okay, so her risk factors were the fall, but people that have been struck in the head, motor vehicle accident, falls, anything that can cause trauma. And then at risk, her age is a risk there. So it's the young, people less than 10 years old, and that's because of sports and bicycles and not wearing helmets and those type of things. And the very old, they say very old is greater than 74. I don't really think greater than 74 is very old. I mean, 74 I don't think is really old, but they do have a loss of balance in their, that's when their motor skills start to deteriorate just a little bit with age. So it kind of starts around that age. Also, people that partake in high risk behaviors, the use of drugs, alcohol, team sports, not wearing a helmet, not wearing a seatbelt, all those things. Those also go along with your education part of this. Okay. So it continues with when you assess the patient, and I'm sorry that's over the top of that, but this is what it says. I'll correct that before I send it to you. When you assess the patient, and sometimes my PowerPoints do that because I have to convert it to PowerPoint from Keynotes, which is on my Mac, and that's what happens. So this says when you assess the patient, you find that she has a Glasgow Coma scale of 13, no focal neurological deficits, and the patient has a 3 millimeter scar above her right eye. So with this chart here, you're in the three different areas. So what is the scale? It's used to response for verbal, eye, and motor skills. Okay. It's useful in monitoring the changes in the acute phase, which is the first few days of the head injury, but it does not take place of an in-depth neurological assessment. Um, if you cannot, so the reflexes, if you cannot get them to respond to tactile stimulation, you can use more of a like the chest pinch or those type of things to really get their cognitive awareness to where it's not a peripheral like a reflex action. Um, their corneal reflexes will be their pupils reacting to light, and their gag reflex obviously is whether or not they have control of the swallowing and function of their throat, which would also be managing secretions. If they can't manage their secretions, their airway is at risk. Okay, so the mild brain injury ends up being a 13 to moderate is 9 to 12, and severe is 3 to 8. I'm going to go back to that so you can see it. So the best eye response, so spontaneous is opening, blinking at the base. That would be their highest number. And then obviously they have none of it. That's their lowest. Verbal responses, if they're oriented, is their highest. And incomprehensible speech and none is their lowest. And then the motor response obeys commands and movements. And then if they have posturing or are unable to have any motor response, that's their negative none. So she has a Glasgow Coma scale of 13. She got a 3 for eyes. Um, she got a 3 for eyes. For movement, she got a 6, and for vocal, she got a 4. Sorry, with no focal nerve deficit. So, which classification of brain injury does she have? She has mild because mild is 3 to 15. Good. Okay. The patient is now complaining of headache and is impulsive, attempting to get out of bed, despite being told multiple times that she needs to have someone assist her when getting out of bed because of her risk of falling. She is oriented to person and place, but not to time or situation. Continuing to ask to get up to let her dog out and complains that it smells like rubbing alcohol in here. When you ask her to please sit down, she smiles and gets back to bed. So if y'all manipulate the slides on your screen right now, for everybody. Okay. I'll send it out and y'all have that at the end of it. So this is a primary brain injury that she had from her fall. The primary is the initial part of the brain injury, and then there's secondary injuries that happen because of that, and we'll get into those in a minute. But what are some of the early signs and symptoms of brain injury? How do they present? Yes, confusion. They have a change in level of consciousness. hmm So they'll have a headache. They can have sensation of pressure in their head, sometimes nauseated and vomiting. Slurred speech would be an early sign. A delayed response to questions, where you ask them a question and then they seem like they're trying to think to give you the answer instead of just what's your name, and I'll say, Miss Reljak, instead, well, it's Miss Reljak. There's that delay in there. They have some confusion. They can have dizziness, and they can have ringing in their ears. They have memory loss, and they're also fatigue. So, what are some delayed signs and symptoms of brain injury? And by delayed, I mean they come on a few days later. They can have posturing. That's more with a moderate type, but that is delayed. What about persistent memory loss or trouble concentrating? The memory loss is part of the amnesia. Seizures, yes, they can have seizures. They're irritable. They have some personality changes, sensitive to light and noise, and their taste and smell will be off. It's a disorder that where they can lose it. Not usually happens after a head injury. They also have sleeping problems, mood swings, and stress and anxiety. Then mild traumatic brain injuries, a lot of the same signs and symptoms we just went over, but there's some difference between the mild and the moderate. The mild is the loss of consciousness, and it can be for a few seconds. In mild, they either have loss of consciousness for a few seconds or they don't have any loss of consciousness. Their concentration can be affected. They'll have headaches, the dizziness, the vomiting. Vomiting and nausea are almost with every head injury like this. They have the mood changes. They have difficulty sleeping, or they'll be sleeping more than usual. And then with your moderate to severe brain injuries, they'll have an absolute loss of consciousness, whether for several minutes or hours. They'll be agitated, they're combative, their inability to awaken from sleep. They'll have slurred speech, weakness and numbness in fingers. They have a loss of coordination. They have that headache that's just persistent and it gets worse. They have seizures. And then you'll have the dilating of one or both of the pupils of the eye. And how do children's symptoms differ from adults? How do you think they present? Because they can't really explain some of the sensations that they're feeling. So how do you think they show you? Yeah, there'll be persistent crying and inability to console. They're irritable. They don't feed well. Yeah. So they change in the eating or nursing habits. That persistent crying and inability to console. They're very easy to become irritable. They lack that ability to pay attention. The change in sleep habits. And they usually lose interest in the things they usually like to do, like that favorite toy or activity, because they just don't feel good. And yes, their fontanelles will bulge, and that would be an assessment symptom that we would find. You all good so far? Thank you. I feel like I'm talking to myself. Okay. So your primary brain injuries are the skull injuries, and there are different type of skull fractures. You have your linear, which is just the singular fraction line. You have the comminuted, which is the splintering or the shattering of the skull into pieces. And the depressed is exactly what it sounds like. It is the actual indentation of the skull. And brain injury. So the frontal lobes, what is your frontal lobe responsible for? Mood, yeah. So it's responsible for your behavioral output, your social and your cognitive behaviors. So inhibition, um, self-regulation will be affected. Their abstract reasoning, their attention and working memory, their executive function. And when I say executive function, I mean being able to multitask and organize, and their movement. Their muscles involved in speech and facial expressions will be affected. And this region of the brain is usually affected when motor vehicle accidents, and it's usually caused by that rapid acceleration and deceleration type event. Okay, so that's the inhibition, initiating behaviors, self regulating, abstract reasoning, attention and working memory, executive function, and movements. And that's your frontal lobe. Your temporal lobe, what is this responsible for? Yeah. So it's your text. It's for comprehension and production of the spoken language. So it's speech center. Um, Memory development learning is in there. Auditory input, progression of that spoken language, and comprehension of spoken language, and also language production, choosing the appropriate word, the fluency of spoken speech. And when I say fluency of spoken speech, I'm talking in a normal manner right now where all my words are flowing as opposed to trying to get something out in broken up words like that. Okay. And then you have your parietal lobe. What's it responsible for? Yeah, it's responsible for those complex behaviors that involve your senses. So, your body positioning and movement, your sensory perception, um, the right to left differentiation, your self awareness, and that self body awareness. Yes, that's right, body awareness. And also the ability to perform mathematical. Okay. And your occipital lobes, what are those for? Vision, that's right. Okay. So these injuries, they can lead to visual impairment such as blindness and blind spots, visual distortions. That would be double vision or seeing spots, and visual inattention, where they just can't really focus in on what's there. Um, the recognition of what something is visually, they can see what it is, but they cannot tell you what it is. Like they can see the object, but they cannot verbalize the word for it. And then the brainstem, you all know it controls the most important functions of the body. What are some of those? What is basic brainstem function? That's right. Breathing, heart rate, respiratory rate, all those things you don't think about that your body does automatically. It controls your blood pressure, your digestion, your temperature of your body, um, your alertness, your ability to sleep, your sense of balance. It's a very important part. You've probably heard people that have injuries sometimes they'll refer to as they have basic brainstem function, where the body is just doing what it's supposed to do and the person really isn't there. Okay. And then we have the cerebellum. It's responsible for that movement, balance, and equilibrium. It also controls and develops the memory for fine reflex and motor acts. So all those like writing, that's a skill. All those type of fine motor skills. Okay, y'all have any questions about those? It's important for you to know um, what area is affected. Like if someone explained to you what their symptoms were, you need to be able to have an idea of what lobe has been damaged. Okay. That's part of the body positioning, like décolleté, where it all comes in. I call it the reflexes into the body with brain damage, or the arching of the body. It's the positioning of the body, the positional arching. Okay. Basilar skull fractures. I put a little image up here. You can see the anterior fossa, the central skull base, the middle fossa, and then the posterior fossa. About 70% of the skull fractures are in the anterior fossa. It affects the cranial nerve 1, which is, do y'all remember those? It's the cranial nerve for smell. And when you hear about raccoon eyes, it's this edema and this hemorrhaging that's very pronounced right around the eyes. Okay. Well, you are in nursing, Jessica. It is kind of scary though. I look like that sometimes whenever I have allergies. Just joking, it's not that bad. Yeah, nursing is scary. They also have rhinorrhea. What's that? Runny nose. What's the running? It could be leaking CSF fluid, so you have to watch that and make sure. Okay. This is the middle fossa. It's the weakest. It affects the cranial nerve 7, which is eye movement. They have mastoid hemorrhaging and battle signs. The picture of the bruising behind the ear, that's the battle sign on both of these patients. I hope they're not too dark. I couldn't get them very much lighter. So that's a telltale sign of a skull fracture also. What's autouria? Mm-hmm. Ear drainage. And that could be leaking of CSF fluid from the ears. And then this is the posterior fossa. They are uncommon. I think it's around 5% that are the posterior fossa skull fractures. It affects a lot of the cranial nerves, as you can see, and these are the cranial nerves for taste, sensory motor, muscles used for head movement, and muscles of the tongue. And then they can also have an occipital bone fracture back there. Okay, so your patient has a GSC of 13 and the inability to stick out her tongue. What is the most likely basilar skull fracture associated with this deficit? What do you think? Anterior, middle, or posterior? Yep, it's posterior. Okay, good job. What's a focal brain injury? Okay, it's that localized area. That's right. It's not the whole brain involvement. So think about the coop. There's a picture here of, you see that the very first one is the impact, and that's where the actual coop is. And then the head, the brain inside the head moves forward and slams against the front of the skull, and that's the contracoop. Okay. And those are contusions that happen, and that's just bruising of the brain. Where's the most common area of this injury? Where do contusions usually happen in the brain? Which lobe? Yeah, frontal or temporal lobe. So either one of those, frontal or temporal. And what's the injury site? What's the impact called? Where the injury site is from the impact? Yes, that's right, coop. And then the injury on the opposite side of the impact is the, good job. Okay, so what's the challenge with contusions? So you have the altered level of consciousness. So these patients, they can be conscious, they can be stuporous, which means like confused, not they're there, but they don't really know what's going on, or they can be absolutely comatose. And you need to know when you're assessing these patients, confused, are they agitated? Do they need airway management? Are they alert enough that they're managing their own airway and able to do their secretions? Then you have the bruising. And the bruising causes edema, right? So that causes swelling and causes more pressure. And then when they bleed into that bruise, into that contusion, what do you need to monitor? Yes, P, that's right. Good job. So seizures, they can be clinical or subclinical. What are subclinical seizures? Clinical would be that yeah, almost absent seizures. So the clinical would be the one that presents in that clinical manifestation where you have all those signs and symptoms and the patient's doing exactly what the textbook said they would do. And then you have the subclinical, which is, yeah, they're not really symptomatic, but you can see their vital signs may change. There are ways to see that when you're monitoring them. And so that's why you need to provide that continuous EEG monitoring because you can see the activity in the brain. And then you have your epidural hematomas. I'm really sorry about this, guys. I will make sure that it's fixed before I send it to you. Um, where's the bleed during an epidural hematoma? Well, first of all, is it an arterial or a venous bleed? Arterial, good job. Okay, so where is it? Yeah, between the skull and the dura. It's most frequently caused by a tear in the artery from a skull fracture, and they can present conscious, unconscious, walk and die syndrome, where you think they're okay, and then they go unconscious, and then all of a sudden gone. And this is a medical emergency. Why is an epidural hematoma a medical emergency? Well, we know it's bleeding of the blood into the brain. Medical emergency for multiple reasons. Yes, it can herniate, but they can also go into respiratory arrest because of too much pressure. Good job. I have to tell y'all probably don't like class this way, but I really like the chat thing on the side because y'all are nonstop in there, and this is the same way at the end of last semester, and it really helps me see how you're thinking. So I enjoy it. Okay, so what are your challenges with epidural hematomas? We talked about how to prevent that brainstem herniation. So what would you assess for with herniation? What would that look like to you if you are going in to assess a patient? Dilated pupils, yes, dilated and fixed pupils, right? A decreased level of consciousness. They can, yes, abnormal respirations they can have, and they can also have hemiparalysis, which that's paralysis on one side. Okay. Also, the presence of arterial bleeding is a problem with the epidural hematoma, and neurosurgery needs to be consulted to decide if they need to evacuation and repair to prevent the herniation. And then we have our subdural hematomas, and this bleed is between the dura and the arachnoid. Um, the acute subdural hematoma, when do these symptoms occur? What's your time frame there? They occur before 48 hours. So less than 48 hours is when you're going to have the symptoms from the acute subdural hemorrhage. Um, and it's basically the same. I'm not going to go into a unical herniation. It's basically the same thing. Just think of it as a brainstem herniation for y'all's benefit, but it's the herniation of that type of brainstem. Okay. So the signs and symptoms are rapidly increasing subdural hematoma. What is your number one? Yes, Jessica.
If the epidural was the meningeal artery, would you say the superior sagittal sinus and the bridging veins, that is what, if that is the initial injured area?
Yeah, that's where the bleeding's at. That's the
Okay.
venous bleed.
Okay.
Is it good? Okay. So rapid, okay. So the rapid increasing subdural hematoma, you'll have those changes in level of consciousness, and that's one of the earliest signs um, of your increasing ICP. Okay, you'll have decreased reactivity of the pupils. They can have the um, increased blood pressure, decreased heart rate. That's how they start to show those signs. And then the subacute subdural hematoma, these can happen for up to 2 weeks post injury. Okay. And then your chronic is just what it says. They occur after the 2 week post injury. Um, and who do you think this usually affects the most? Elderly, yes. And who else? Can you think of anybody else? Not as much the young adults, but elderly and alcoholics. And think about, this is chronic subdural hematoma. So this is the chronic bleeding. You're not able to get it to stop, and it's continuing to leak a little bit. So elderly patients, as they get older, their clotting factors change, right? And then alcoholics. What is alcohol? What does it do? Alcohol thins your blood. That's right, it's a blood thinner. So if you have someone who's an alcoholic, they're also going to continue to bleed. So that's the ones that it usually happens in. So what's the challenge with the subdural hematoma? You're going to monitor that level of consciousness. And how are you doing? Why are these serial neurological exams so important? You know what I mean by serial? So multiple, very close together in a row over a certain amount of time. That's right, so that you can notice a change, early detection. Mm-hmm. You're also going to be watching them for the seizure activity, and they'll get a CT. And what's the CT going to show you? The bleed. It's going to show you the location. It's going to show you the size of the bleed. Okay. Then you have your surgical evaluation and drain, and they do these for acute subdural. They do a craniotomy, and then for chronic, they do the burr hole evacuation. So remember, craniotomy is for acute, burr hole is for chronic. These both alleviate intracranial pressure and evacuate the blood. You can also do subdural drains. These are minimally invasive. They're usually a bedside procedure with a little bit of local anesthetic, and it's a closed symptom type of evacuation where it's constant removal. And then position of the head of the bed. Why is this important, and where should the head of the bed be? Okay, so y'all's answers about the position, they were all over the place too whenever I was reading through this stuff. The one that I found most consistent is 30 to 45 degrees, but know when they're laying down, or, the pressure can be the highest because they can't auto regulate. Okay, so just make sure they're head of the bed up. The only time that they should be flat is if it's a chronic cerebral bleed. Then they lay flat for about 40 hours after the trauma for risk of reaccumulation of blood. Someone who has a chronic bleed, they maybe it's an elderly person who falls in, then they need to lay flat for 48 hours. Does that make sense? Okay, which part? Eunice said no.
For chronic ACDH, you lay them flat for the first 48 hours?
After a re-injury.
Oh, okay.
So like an elderly person who has a chronic bleed, and then say they fall at home again, then you lay them flat for the first 48 hours. The general rule is that they stay upright. The position of the head of the bed should be at least 30 degrees, 30 to 45 degrees. Okay, and all those things decrease that ICP. Okay, so you have primary brain injury. These are diffuse injuries now. So this mild head injury is concussion. That's caused by shaking of the brain and shear stress and a reticular formation. Um, this disrupts the brain's normal chemical balance. And this is a non-focal neurological defects. And then when you assess for a post-concussion symptoms, what are those symptoms? What's someone who's had a concussion? How are they presenting? Yes, they'll have headache, memory. What about their memory? Memory loss, confusion, they forget things. They'll have their personality, they'll have a temperament will change. They can lose their temper easily, become impulsive. They have difficulty with new learning. Okay, personality changes. Good. Okay. Diffuse axonal injuries. These are concussions that cause damage to the brain's neurons. So the mechanism of injury is that acceleration and deceleration, and it causes widespread shearing. And this causes stress on that gray and white matter. T will show you, CAT scan results will not show you the actual lesions on this, and an MRI is the one that will predict the length of the coma and the diagnostic test for this. Okay, so the reference and diagnostics test for this type of concussion is the MRI. And these are graded in 1 to 3. And pay attention to the loss of consciousness in this. So in a grade 1 is a brief loss of consciousness, and brief is seconds, okay? And then you have recovery that's possible. On a grade 2, it's a coma of duration or unclear recovery. It makes it an unclear recovery process. Coma of duration would be a minute. They say coma, but it's more of loss of consciousness. If they're out for a minute or greater, that would end up being a grade 2. So if you're hitting the head and you're on the ground and you're not unconscious for a minute, then you probably have a grade 2 concussion. Okay, and grade is immediate coma, and you have that posturing. You usually will not have a complete recovery with a grade 3. Okay, so this is case study number 2. This patient presents as a 35-year-old female in the neuro ICU, status post motor vehicle crash. She suffers from the following injuries. She has a traumatic right temporal intracranial hemorrhage, a traumatic subarachnoid hemorrhage, right 3 through 6 ribs fractured, and a right radial fracture that has been reduced and splinted. Your patient's vital signs this morning are as followed. Her temperature is 98, her heart rate is 116, her blood pressure is 88/56, respiratory rate is 18, pulse ox is 97, she's on a 2-liter nasal cannula. She has no past medical history and has no medication at home. CBC shows a hemoglobin at 10, hematocrit at 30, and their chemistry panel is within her. Last narcotic was given at 10 p.m. last night. And the patient's pain is a 5/10. Okay? Keep that in mind when we start going over these secondary brain injuries, which we're going to start now. Okay? I have a question for you at the end about her. So secondary brain injuries, and what do I mean by secondary brain injury? That's right, due to the primary. So it's a cause and effect situation. You have the concussion, and then you have something else that happens that can cause brain injury with that because of the concussion. Okay, so hypoxia. We all know what hypoxia is, I hope. So any degree of respiratory failure is very hazardous to a patient that has a brain injury. And why is that? Obviously respiratory failure is going to lead to death if it's not treated, but it can cause hypoxia, and you have that loss of consciousness. which can cause decreased respirations, and that can lead to severe hypoxia. Hypoxia will aggravate cerebral ischemia and increases cerebral blood flow and cerebral blood volume. And what does that do? If you increase that cerebral blood flow and blood volume, what does that do? What does it also increase? Yeah, it increases your ICP. So one of the most important goals in the management of head injury, what do you think that is? I know you want to keep the ICP down, right? But with hypoxia, what is one of the most important in managing a head injury? Oxygen. How are you going to get oxygen in them? You have to establish and maintain that adequate airway. Okay? Is it obstructed? What can cause those obstructions? So when an airway is obstructed, that causes carbon dioxide retention, right? And you can also have carbon dioxide retention from hypovolemia, someone who's breathing on their own but not good enough. And what do these two things cause? What does that carbon dioxide retention and hypovolemia cause? Do y'all know that? So a buildup of carbon dioxide will cause your vessels to dilate. So cerebral vessel dilation. When you have vessel dilation, what does that cause? Increased ICP, that's right. Think about this again. Let's go over it one more time, okay? You have an obstructed airway. That obstructed airway can lead to carbon dioxide retention, and hypovolemia can cause that too, right? When you have hypovolemia with carbon dioxide retention, you have that hypoxia. Okay, hypoxia causes those vessels to dilate and causes the increase in intracranial regulation. Does that make sense? Rebecca's like, okay, yeah, it might make sense. I can explain it a different way if y'all need me to. Just know hypoxia causes that buildup of CO2, whether it's from the retention of, so not having a respiratory rate high enough, or having a respiratory rate that's too low. Okay, and then that causes that dilation of the vessels, and that causes the increase of ICP. Okay. Okay, hypotension. So that's a little deeper, Thomas, talking about hyperventilating trauma patients. That's done to be able to maintain and manipulate their gases on what's going on with them. You want to keep them within as normal as possible with their ventilation, but sometimes you have to give them a little bit more CO2, okay? You have to allow their body to have, a little less CO2. And with that, that causes their respiratory drive to go down. So they're usually vent management in that case. Does that make sense? Okay. So hypotension, it has been correlated and shown to correlate with brain swelling. And that's because of that autoregulation. If the autoregulation remains intact, the systolic blood pressure changes, like a drop will trigger your autoregulatory system to maintain that blood pressure and that adequate perfusion. Okay, so if your autoregulating pressure is intact, then if your systolic pressure drops, your body is automatically triggered to go and fix this and maintain adequate perfusion to your whole body, not just your brain, your whole body. Okay, and if autoregulation is not intact, then this dependency on the systolic blood pressure will be needed to prevent the ischemia. So ischemia, if you're not adequately perfused, ischemia is going to cause death, right? No matter where it's at. We're talking about cerebral ischemia right now. Okay, so very important part. You start having brain death, you have a whole nother problem. So hypotension, just like when you study about the kidneys and everything else, you need everything to be perfused. You also need the brain to be perfused. And if your autoregulation is able to do that on its own neurologically, then you're going to have to help them. And these things, being inadequately perfused, just like with any other part of the body, will cause ischemia. And then you have cerebral edema. There's multiple reasons for cerebral edema. It could be, in this situation, it could be fluid overload. It could be because of the swelling in the brain. And it can last to 2 days. Longer, it can be out 5 to 6 days, and sometimes it peaks late. So just know cerebral edema is something that happens in brain injury, and it's not unnormal to see it come very quickly, but last longer, and sometimes it doesn't peak till later. And that usually has a lot to do with your electrolytes. So without having to give you a definite answer on what to look for that, it plays into if you have someone with cerebral edema because you gave them too much fluid and made them hyponatremic by giving too much fluid, who knows what day that would happen on. Does that make sense? We'll get to Manson in just a little bit. Okay, now I'm going to check your understanding. Okay, so your vital signs this morning are as followed. You have the 98 temp, heart rate of 116, blood pressure was 88/56, respiratory rate's 18, pulse ox is 92 on 2 liters, and the last narcotic was given at 11 p.m. last night. The patient's pain is 5 out of 10. When you walk in to assess your patient and notice that they have difficulty awakening, the most likely reason for this change in mental status is what? Hypotension, that's right. Good job. It's the hypotension. Some people have done this before, and people will say they're narcotic, but it's really not enough to overdose her. Okay? So because of that decreased cerebral perfusion, it results in that change in your neurological function. Think about when you, and this is really kind of, I have some weird things to equate things to sometimes, but think about when you sit on your foot and it goes to sleep. Okay, well, that's what happened to your brain. Your brain did not have enough perfusion. So your brain would naturally be confused. Okay, so that's what happens in a trauma patient. Okay, we're going to go into assessment. You have a year-old female patient whose status post-motor vehicle crash were brought to the emergency room by EMS. She's not conscious and on supplemental oxygen via a non-rebreather mask en route to the hospital. In the emergency room, she's attached to the cardiac monitor, continuous pulse ox, and a full set of vital signs are taken. 12 lead E and lab work are quickly obtained. Then the nurse performs a head-to-toe assessment of the patient, including a full neurological exam. Due to the patient's decreased level of consciousness, the patient is unable to participate in some of the aspects of the exam. So it is modified to still obtain as much information as possible. The subjective history is limited at this time due to the patient's mental status and will be obtained once the family member arrives for the interview. So with history, you need to know anything that's important about their past medical history, including acute and chronic medical conditions that could affect their treatment, and also that could affect their plan of care if their patient is a trauma patient now. You need a list of their at-home medications when they're available. Obviously, this patient's not going to be able to tell you that because she has a decreased level of consciousness. So you'll get that from the family members when she gets there. They get there. And then you need to know any known allergies of the patients, obviously, so that you don't give them anything that they're allergic to. You need to obtain a social history to know about alcohol use, tobacco use, recreational drug use, and behaviors known to modify injury risks, such as seatbelt use, like motor vehicle accident, was she wearing a seatbelt? Okay. So when you're doing an assessment, how do you assess and diagnose injury? How do you assess and know the extent of an injury? What parts of physical assessment? Parella, that's right, but what's Parella part of? Parella is part of a what? That's right, neurological exam. Good job. So her immediate health history should include what? Think about that. Immediate history, you want to know what's going on. You want to know, when did this occur? When did this injury occur? Did it occur 10 minutes ago? Did it occur, 6 hours ago and she's coming in? And what caused this injury? right? Did something fall on her head? Did she fall? She hit by a missile? Like, you never know, okay? You want to know if the patient's conscious or has amnesia after the fall. And so if it's unconscious or has amnesia after the fall, what does that indicate? What type of injury? I'm not asking you to grade it or anything, but if you're talking to someone and they're giving you this and they're telling you this patient was unconscious and talking about a significant type of brain injury, right? We're not talking about just a contusion. We're talking about she's has a concussion of some type and it's significant. What else is important to determine when you're doing this assessment? You want to know if this patient lost consciousness. If they did, what was the duration of the unconscious period? Was it minutes? Was it seconds? Are they still unconscious? And what's the most sensitive neurological neurological indication for deterioration of a patient's condition? Yeah, their level of consciousness. And always go back to that when your assessment, the LOC. Okay. The LOC, it will precede all other changes in vital signs. So you'll see that change in level of consciousness before it shows in that patient's vital signs. Okay. So this detailed assessment needs to be done initially, so you have the baseline, and then it needs to be done in frequent intervals during this acute phase. And we asked you that earlier, and y'all told me so that we can watch and see if the condition is worsening or what are the subtle changes in signs that could possibly be overlooked if you only did it once every 12 hours. Okay. You also want to know about pre-hospital treatment. How did EMS find the patient upon arrival? The interventions performed by EMS, what medications did they give, and what were the changes in the patient's condition en route to the hospital. Okay. So here, the patient's outpatient care is provided by a physician associated with the hospital, and many aspects of her medical history can be found in the electronic medical record. The patient's pertinent medical information history includes the following: a chronic systolic heart failure with more recent ejection fraction of 35 to 40%. She has chronic kidney disease of stage 3. She has diabetes type 2 with a recent A1C of 7.8, and she has chronic atrial fibrillation. She does not have any drug allergies, and she has a pretty extensive medication list. Okay. Now we're going to go to our EMS report. So they provide the following report. They arrive on the scene to a two-vehicle crash or collision. The patient's car appears to have struck another car from behind. The patient was found in the driver's seat without her seatbelt on. The patient's eyes were open and she was responsive to the team. She was mumbling incomprehensible words when questioned and in all four extremities. Visible contusions of the front forehead where it likely struck the steering wheel. And the patient was removed from the vehicle and placed in the ambulance. Vital signs 114, blood pressure was 134/90, respiratory rate was 24, SAT was 88 on room air. They placed her on a nasal cannula, and she became less responsive, and the SpO2 continued to fall. So the patient was placed on a non-rebreather mask and was stabilized at 94%. Blood glucose is 210. Patient only opened her eyes in repeated stimulation and eternal following commands. She arrived in the ED and handoff of care is completed. When the family arrives, they state she's a former smoker with half a pack a day, and she quit smoking 40 years ago. She does not drink alcohol or use recreational drugs. So based on this patient's past medical history, what potential complications should the nurse be vigilant in monitoring initially? This acute pulmonary edema, bradycardia, venous thrombosis, or acute kidney injury. Okay, we got a little bit of all of them. So the answer, and I'll go over the reason why. The answer is acute pulmonary edema. Okay. Her reduced ejection fraction. is potential for the high volume of fluid administration that's going to happen, makes her at risk for that pulmonary edema. That reduced injection fraction is going to mean she's not going to handle that increased body of volume. And, she's not going to be able to handle that, so she's going to reduce the cardiac output and put her at risk for heart failure. Her chronic kidney disease, it can cause her to not be able to handle the fluid also and not be able to get it out of her body. So not being able to eliminate it fast enough to get it out. Okay. So on your assessment, ABCs always. The answer wasn't both. The first one, it's not really two parts. It's potential complications should the nurse be vigilant and monitoring. That's going to be her heart failure because of her injection fraction and the possibility of increased fluid. You don't want to fluid overload her. If that happens and you fluid overload her chronic kidney condition is going to come into play. So yes, possibly both, but only if the other one happens. Make sense? Sometimes I always feel like my answers have a catch-22. Okay, so on assessment, your primary assessment is always ABCs in this type of situation. And airway, okay? So we talked about what's the most important goal in this management, and that's to establish and maintain that airway. That obstructed, always, and they always have about 3 of the 4 answers could possibly be right. That obstructed airway, remember, can cause the carbon dioxide retention, which will cause the dilation, which will cause increased ICP. And a lot of times with trauma, you have that edema from swelling of maybe a facial injury or even throat or infection, or you have a foreign body, burns, anaphylaxis, anything like that will affect secretion management. And that's the most common in neurological disorders is secretion management. So they may have to have an artificial airway to maintain a patent airway, okay? So not being able to handle secretions may cause a reason for them to have a artificial airway placed for protection, okay? Their breathing, what do you want to know about their breathing? How are you going to assess their breathing? Yeah, their respiratory rate. So you're going to want to know their respiratory rate, breath sounds, and that respiratory pattern if they're not on a vent, because the ventilator is going to be giving them their own pattern. Your respiratory rate, what can your respiratory rate tell you? If you have a high respiratory rate, what's your body trying to do? Trying to compensate, that's right. So if you have a high respiratory rate, your body's trying to blow off some of that CO2, right? Low respiratory rate, it's trying to hold on to CO2. What else do you want to know about their, well, I shouldn't say necessarily breathing, but it needs to know this so you can know if they can protect their airway. Is their cough or gag reflex intact? You need to know that for airway protection. And then what lab value is done so you know if they're being adequately managed respiratory wise. ABG. And then you definitely want to try to keep their O2 sats greater than 90. And why is that? We've talked about it already. What happens if the respiratory rate is less than 90? Hypoxia. And what's hypoxia cause? That's right. Good job. You'll see how this works now? You'll see how I loop y'all all the way back around and ask a bunch of questions. Okay, then circulation. So how are you going to assess the circulation? Well, I hope that, okay, good. I'm glad you love it because some people don't love it, but that is what it is. You're in my class this semester and I will try to help as much as I can if you don't love it. But it allows you to critically think, and critical thinking you can't teach. It's all applied knowledge, so it's a little harder. I'll get to that in just a minute, Thomas, whenever I get to how we assess for it's more perfusion, it's more managing the perfusion of the brain and the evacuation of blood as far as what we're studying here. Okay. So circulation, how are you going to assess the circulation? You're going to monitor that heart rate and the blood pressure. What do we want to maintain our systolic blood pressure? What does it need to be at? It should be above 100, and that's going to help with that end organ perfusion. What else are you going to check? Cap refill, which is also your peripheral pulses in cap refill. What's that going to tell you? What's cap refill tell you? That's basic. Yeah, it tells you about perfusion. Good. All right. And then you're going to obtain some type of access on this patient, some type of intravenous line on any patient like this, because you need to have access to them in case you need to either one, resuscitate them, or fluids, to push fluids. You're going to need some type of access. They are going into some type of shock because of a injury. Access is going to be hard to get on them. So key here in any type of situation that's an emergent situation is not to wait until you need that line to be put it in. Start putting it in as soon as you possibly can, so that when you actually need it because the patient's coding or in shock or whatever it is, you're not then trying to put an IV in or a central line in a patient and you can't even find a vessel at that point to put it in. Okay. Okay, so next is your vital signs. What vital signs do we need to watch? We just talked about your cardiac monitoring, your pulse ox. You're going to have some type of invasive artery blood pressure monitoring. And end-tidal CO2, what, do y'all know what end-tidal CO2 is? What is it, Thomas? Yeah, your CO2 on expiration, and it's hooked up to a vent usually to tell you what that level of CO2 is on the expiration of the breath. Yes, end-tidal CO2. That's right, Jessica. No, that's okay. Okay, and so then after that, you need your temperature monitoring, and your temperature should be maintained at less than 100.4. And what would a rapid increase in temperature indicate in a patient with brain injury? What manages your temperature in your body? It's an indicator of possible brainstem damage, and it has a poor prognosis, and it's usually involved with the hypothalamus. Why else is hyperthermia bad for a patient with brain injury? So if you have brainstem, if you have the fever from a regulatory problem, it shows that you have a good bit of damage to your brain, right? But why else is that hyperthermia bad? When your body temperature goes up, what else increases? Your metabolic demand increases. Yes, increase. That's right, increased metabolic demand. And you don't want to have an increased metabolic demand right now. Okay, not with your body trying to heal. Okay. So, what vital sign would show you increasing ICP? We talked about this a few minutes ago. What would your heart rate be, high or low? Low, that's right, your heart rate's low. And then if your heart rate's low, what usually happens with your blood pressure? Yeah, think about it this way. If your heart rate's low, it's pumping slower, but your body still needs to keep blood pressure at the same, right? So your blood pressure is going to go up. I mean, try to keep the blood volume in your body the same. So the pressure of that volume. So your blood pressure has to go up to make up for your heart being low. Okay. And Cushing's triad is three things. Obviously the triad part, but it shows increasing ICP and the effect on its body. Yes, I'm getting to that right now. So Cushing's triad increases systolic pressure with widening pulse pressures. It decreases the pulse rate and the change strokes respirations. The increasing ICP, if you have these three things, this Cushing triad, it is very much well established when this occurs. So it's not just happening then, it's something that's been going on for a little bit of time. Okay, so that's the increase in systolic pressure, the widening pulse pressure, decreased pulse rate, and the Shane strokes respirations. Now, what did your vital signs show as your brain compression increases? So that pressure on the brain, what's going to show? Your respiratory rate becomes very fast. Oh, good question. I try to come up with good ones. So we just talked about what happens when there's increased ICP in your brain. Okay, that was the one we just discussed. Now, more compression of the brain. As that compression of the brain increases, that's going to tell you that those symptoms are going to get worse, right? So your respiratory becomes very fast, very rapid. Now, what happens to your blood pressure? What happens to your body when we try to compensate? Your body is all gun ho and tries it for a little while, and then it's like, man, I'm not getting anywhere on this, and it tires out. So what's going to happen to your blood pressure? It's going to decrease. That's right. Okay, and then, so if your blood pressure decreases, what's going to happen to your heart? Body's giving out, though. Remember? No, at this point, your pulse is going to slow. Usually, and you're thinking right on that, usually when your blood pressure decreases, your heart rate goes up to make up for that decrease in blood pressure. But with this brain compression increase, this is a very serious part of this. And so your body is already past that point of compromising and trying to make up. So your blood pressure and your heart rate's decreasing also. The reason why tachycardia, you're thinking of tachycardia and hypotension would indicate what? So brain compression is bradycardia and hypotension. But what would tachycardia and hypotension possibly indicate in the body? Shock from what? You're right. Shock from what? Bleeding out. That's right. So tachycardia and hypotension can indicate bleeding out somewhere in the body. Okay, so let's start at the beginning of this. Increased ICP, you're going to have bradycardia. You're going to have an increase in that systolic pressure because your heart rate's lower. You're going to have the Cushing triad that's going to show up. Okay, then you're going to have the brain compression. It's going to get worse. And when the brain compression gets worse, what happens? Your respiratory rate becomes rapid. Your blood pressure decreases. Your pulse slows. Got it? So with this compression of the brain, think about compressing the brain. We're not at a point where it can compensate anymore. That's why blood pressure and pulse goes down. The Cushing's triad is the increase in systolic pressure with the widening pulse pressure, the decrease in the pulse rate, and the Shane strokes respirations. The compression, the blood pressure is low and the heart is low. So you're already past that triad when you go into compression. Yes, increased respiratory rate with compression. Ineffective, like it's very rapid. It's not effective clearance of CO2 or oxygenation. Make sense? That's right. So you go from the increasing ICP It's worse when it hits the Cushing's triad, and then from Cushing's triad, it goes into the compression of the brain. The compression of the brain is so much increasing of the ICP. Okay, so you start off with ICP, and that's not good. And then you have all the symptoms, and then it gets to the point where it's bad. So you have the Cushing's triad, and then it's even worse. So then you go to brain compression. They're not three separate things. They're the line of one whole of increasing ICP. It goes up. So you start with increasing ICP. You end up at that Cushing triad's place, which is not a good place to be, and then it continues to get worse with the brain compression. That's right, the spectrum. Yeah, literally, it all ends with brain compression if you can't get it uncompressed. Okay, and then you're going to have the continuous monitoring of all your vital signs, but you're going to have that 12-lead echocardiogram done. And what's that going to show you? What does the echocardiogram assess for? I actually think y'all learned this with me later on before the third test, but an echocardiogram assesses for arrhythmias and signs of ischemia in the heart. Okay, and so if this patient developed a new arrhythmia during this time, what could that be caused by? Think of all the things that are changing in this person. So it could be a sign of electrolyte abnormality, or it could be a sign of a hemodynamic compromise, which is something to do with blood loss or pressure. What electrolytes would you watch? This is basic. Y'all should know this one. Potassium's right. What else would you watch? Calcium, that's right. Potassium and calcium I'd really watch if I had abnormal ECG. Sodium's going to cause brain swelling. Is it hypernatremia or hyponatremia that causes brain swelling? That's right, hyponatremia. Y'all hear it, they give babies water sometimes or try to dilute out their formula to make it last longer. Don't ever do that, but it happens. And the reason why the kids start seeing is because their sodium level drops so low. It causes the brain swelling, the cerebral edema. Okay? And then you have your lab work that we're going to do. So CBC, why do we want a CBC on this patient? What are we looking for? I'm going to get that with the PTT and the INR, the PT. What are we going to get with CBC? Yes, so we want to know about when you're getting the crit and the hemoglobin, what do those things tell you? The H and H, what does the crit and hemoglobin tell you? Bleeding, that's right, blood loss if they're bleeding. And what else? Adequate amount of what kind of blood? What in that blood? Oxygenation, there you go. So anemia. So with this CBC, you really want to focus in on the hematocrit and the hemoglobin because you need to know if you're bleeding and you need to know if you have anemia. Well, if you have anemia, your body's just going to try to pump more blood to try to get more oxygen, right? What is pumping more blood or pumping blood faster going to do to an area that can't auto-regulate? Overload. So if you get too much there, what's going to happen to your brain? Edema. What's edema going to do? It's going to increase the ICP. Very good. Okay, so you want to look for the CBC is going to monitor bleeding, and it's going to look for the anemia with your hematocrit and your hemoglobin. Okay, those need to be fixed immediately. So you're going to need a type and screen because of transfusion, right? You want a full comprehensive metabolic panel. You're going to look at everything that y'all just talked about, all your normal electrolytes, and your MAG and your FOS. And what are those going to assess? Your MAG and your FOS will give you some idea if there's kidney or liver injury involvement. Okay? And then your PTT, INR, what's that going to tell you? Yeah, clotting on this patient, right? So are they even more of a bleeding risk? You're going to monitor the ABGs. What are the ABGs? What does that blood gas tell you? What does that blood gas mean? Yeah, that blood gas is the way that you monitor to see if you're effectively ventilating this patient, whether ventilating on a vent with intubated or whether the patient is ventilating on their own. So you're monitoring the oxygen and the ventilation to decide if they're okay on their own breathing or if they need to be intubated. And then your blood glucose, hyper or hypoglycemia caused alert mental status, altered mental status. Hypoglycemia can cause an altered mental status. Okay. Toxicology screen you're going to get. We need to know if there's any level of impairment that's going on. What if this lady is coming home from the grocery store when she has this wreck? But before she went to the grocery store, she was at the bar next door drinking, and she runs into the back of this car, but she's hammered. But we don't know she's filed this toxicology report, so she couldn't answer the question, and she was confused. It wasn't because her head injury was so bad; it was because she was drunk. Okay, so you need a toxicology screening to see if this is really a neurological problem. Is this to this extent, or is some of the impaired cognition just from the drugs or the alcohol use? Okay. And then the other labs that you'll need, and it depends on what's going on with the patient. You can need a BNP, a TSH, all of those. Again, those will depend on the patient. Now you go into assessing the systems, and for the head, you're going to assess for ecchymosis, for edema, lacerations, discharge from the orifice, which we talked about. What would discharge from the orifices possibly be, or a concern for? Good, CSF. And what are two signs of that basilar skull fraction that we talked about earlier? The bad pictures, remember? Raccoon eyes and the battle sign. Otorrhea is 1, 2, and rhinorrhea is 1, 2, but the two signs that are very much should really zone you into a basilar skull fracture are the raccoon eyes and the battle signs, okay? All right, so the neck is the next thing, same thing. Ecchymosis for tenderness, for impaired range of motion. Anytime that you turn your head to the side or tilt your head over to the side, you don't realize it because you have proper autoregulation right now, but it changes if your autoregulation was not properly functioning. Tilting your head to the side or turning your head to your side increases your ICP. So it's really important to keep them neutrally and completely in line, the spine completely in line as far as the head, the neck, and the torso go, so that you don't have anything in that way going against what you're already doing, trying to get the patient's ICP down. If the patient's laying in bed with his head turned sideways and you can't get his ICP down, you know what's going on. Okay. For the heart, what are we assessing for the heart? We're assessing for heart sounds. Why is that rate and rhythm so important? Brainstem, yes. What else? Perfusion. What happens if they're tachy? Talked a minute ago. So think about a heart is pumping out blood, right? Well, if all of a sudden your body is giving feedback that there's not enough blood going, you need more, I need more, I need more, what's going to happen with your heart rate? It's going to go faster to try to get more blood out over and over and over again, right? So that tachycardia is a potential sign of bleeding or possibly shock, but it will be tachycardia with reduced pulses and with some type of cyanosis because it's not effective. It's not effective. How do I want to say it? Perfusion. Does that make sense? Okay. So then pulmonary and thorax. You're going to assess those breath sounds, the work of breathing, the regularity of the respirations, any tenderness on the chest, abnormal movements with respirations, and what would those abnormal movements be? What would they possibly alert you to? If you're watching a chest expand and only one side's rising, or if you're assessing breath sounds and you only hear breath sounds on one side, that's right, punctured lung, pneumothorax. That's right. So if you've ever seen someone, I don't know how many of y'all have seen a patient that's come in that has a pneumothorax, it's very pronounced. Their chest only rises on the side that's actually producing, that's actually expanding. The other side doesn't move at all. It's very pronounced. You can see it, but always know that if you have that abnormal or non-symmetrical movement of the chest, you really need to look into to make sure they don't have a pneumothorax. Pneumothorax, does that show on the x-ray? Yes, it does. Okay, so now you have your abdominal and your gastrointestinal. So you're going to assess the bowel sounds, tenderness, palpable masses, the same as you do with a normal assessment. And what would be a sign of internal hemorrhage or perforation? How would that patient present? The patient's probably going to be bruised a good bit all over if they were in a motor vehicle accident. But to assess for that internal hemorrhage in the abdomen or a perforation of the bowel, it would be tenderness and rigid abdomen. Abdominal distension, yeah. So think about when you're thinking about assessment, y'all know what a normal assessment is. You're really looking for things that aren't normal when you're doing an assessment. I mean, you're not looking for regular bowel sounds, you're looking for the ones that are off. So keep that in mind when you think about assessing a patient. Okay? So that tender and rigid abdomen is a sign of possible internal hemorrhage or perforation of the bowels. A nasogastric tube may be needed for secretions. Multiple reasons here. Secretions that build up in the stomach can cause nausea, make the patient nauseated because of that increased acid in their stomach. It can also cause aspiration if it builds up too much. So the nasogastric tube to be able to drain off the stomach and manage the secretions, make sure they don't aspirate. And then obviously later it can be needed for medication administration and nutrition. Do you want to call in, Nevia? I'll put the number in. Let me put the number in real quick so she can call. Yeah, and I do not care if y'all record my class. I can't record on here and lecture. It doesn't allow it. Okay, there's the number. Okay. And y'all laughing a little bit because now my dog has climbed up in my lap and he's a little bitty dog, but he will start. Y'all can hear it when he starts snoring. Last semester, I'm in the middle of lecturing and someone raised their hand. They're like, "Miss Raljak?" I said, "Yeah." "What is that sound?" "It's my dog snoring." It's embarrassing. What kind of puppy, Thomas? Aw. Okay. So, hold on, sorry. Okay, so that NG2 may be needed later for medication or for nutrition. Then you're going to check to see if they need an indwelling catheter. You also want to see if there's any tenderness or discharge, if there's blood in the urine. You also need that catheter for another reason, and what's that? What's a catheter do? INOs. That's right. So you want a sorry, I didn't have my chat side open. You want a accurate INO because too much fluid causes what? Fluid overload. Fluid overload is going to cause what? Right. Also, if you have an indwelling catheter and your urine output really drops, what else is that telling you? Kidney what? Kidney what? You're almost there. For the kidney to produce urine, it has to be what? Perfused. That's right. So if you have an indwelling catheter in and your urine output goes down, you're probably looking at some type, or with everything else going on, you're definitely looking at some type of perfusion issue. So that's all, can also be an early sign of perfusion issues. Okay, everything's clues. You have to be a detective. Okay, so for that indwelling catheter, it's accuracy for INOs. It also can help you monitor if you're getting too much fluid. It can also show you that you have a perfusion problem. And then your skin, your muscle system, and skeletal system, full body assessment, obviously, for any deviations. Um, Assess for deformities and extremities, fractures or broken bones, and your range of motion in each extremity. Your neuro assessment is that Glasgow assessment we talked about. The scale is 3 to 15. It's commonly used and it is very well known. You rate your motor score. So you have your eye, you have the verbal, and you have your motor response. You rate the motor score on the best limb. And usually, in all the questions that I've seen and the situations, they don't tell you verbal score of 6 on the right arm and 2 on the left arm. Okay, so just know that it's the best limb that gets the rating. It's hard to use with an intubated patient because you're unable to verbalize to get their verbal score, their response. So you can sometimes see it documented without a verbal response because the patient's intubated. Okay. And then your concussion assessment. So this concussion evaluation is used in the emergency department and in some pediatricians and doctors' offices. The tool's available, and I have a link on the next slide so you can look at it. It helps you with a that can show what can happen with each injury, and it also can help further plan care and follow-up needs for that patient. We talked about concussion. I don't think it'll link from here. Yeah, it won't link from here because I'm in. We talked about the mild and early symptoms of brain injury, and that includes the concussion, that loss of memory, that confusion, that irritability. So remember all of those symptoms. And then your post-concussive symptom scale, it's initially designed for athletes so that they could return to sports, but it has these 22 concussion symptoms, and it rates the patient on a scale of 0 to 6. Tracked on this system, you can see it improve or worsen over time. Then you also have for pediatric students, you also have for pediatric patients, students, pediatric patients, you also have the sport concussion tool, which is used in athletes. It's used in athletes and it helps a combination of symptoms for cognitive assessment and physical assessment. And when I give you the email with this PowerPoint in it, that link will be active and it'll show you that sheet also. Okay. Your motor exam, your sensory exam. When you're doing motor and sensory exam, you are assessing for strength and range of motion. You also want to see, is there movement on command? Is it spontaneous? Do they respond to stimuli? You want to frequently assess this. How are you going to do that? When you're assessing their motor or their sensory, what are some things you're going to ask the patient to do? For motor. Move a part of their body. That's right. So raise or lower their extremities. Squeeze hands. What are we doing to squeeze your hands? Strength, and not only just strength, What else? If it's equal, that's right. So compare the strength, and if it's equal, either hand or both hands, by asking the patient to squeeze. You have them push against your hands with their lower extremities, so you can see what their strength is in their legs and their feet. You're going to observe for signs of spontaneous movements. What do I mean by spontaneous movements? What's spontaneous? Not purposeful. So are they moving without you asking them to do something, right? And then if there's no spontaneous movement, assess the response to painful stimuli. How would you do this? How would you assess response to painful stimuli? If you have a patient that's is not in a coma but is in and out and level of consciousness, spontaneous movement is not abnormal movement. Spontaneous movement is being able to move spontaneously on their own. Sternal pinch, yes. Sternal pinch would be how you would assess for painful stimuli. And that involves pinching the pectoral muscles is where you get the best response. Why do you not want to use like peripheral, their hand or their forearm? What kind of reflex? So you may get, you know, when you hit someone's knee and it goes, that reflex in the knee goes out. So if you go and you pinch someone in a hand, tell them to move, but it's not a movement, it's just a reflex of the body. Okay, so that's why you want to do a central type of stimuli, which would include the pinch in the pectoral muscle. Assess their speech. You're going to find out if they can speak one, but then what do you want to know about their speech? What are characteristics of speech? Slurred? Coherent? Are they, yeah, can they, or does it not make any sense? Are they forming words? Mixing words? What about their sentence structure? Are they repeating words? Yes, the flow. What else about speech? Have you heard about people that get hit in the head and all of a sudden speak with a big accent? That's a characteristic of speech. Word loss, where they can't find the words to say. What if all of a sudden they're talking really, really soft, or they're screaming words? Okay, so those are all characteristic speech. And then you have to assess for the eye movement. What do you want to know about eyes? What's the big thing? You do it every time. Equal. Equal in what? Pupils. Equal and active to light. There you go. That's right. So pupil response to light. What do you want to know about these pupils? Their size. Are they equal? Do they react to light? What do I mean by equal? If only one is dilated, or is a poor response to the pupils dilating, what can this indicate?
I think if like the left pupil is dilated, there's injury to like the right side of the brain. It's like the opposite
So
side
there's
of
a hematoma damage. They do have brain damage and a hematoma. That's why you always check patient size that have had head injuries. And then that's why it's like part of your neuro assessment. If they're both fixed and dilated, that shows an acute injury and usually upper brainstem, and it's a poor prognosis. If they have dilated pupils, they're probably just there. Ipsilateral is same side. So like if they're right side and it was happening to right pupil, that's ipsilateral. pupils reveal that there's damage. It depends on where it's at. Okay, so irregular or sluggish response or fixed or only one side fixed, then you know that there is damage and a bleed somewhere or a hematoma. The worst one is obviously the fixed and dilated, and that's the brainstem is damaged in some way. What are other neurosigns? Sensory signs. What's anosmia? What's anosmia? Yeah, the loss of smell or taste. Aphasia. What's aphasia? Yeah, difficulty swallowing. What's difficulty swallowing going to affect? Breathing, because they can't protect their airway. Nutrition, right, because they can't eat. Aspiration, they can't manage their secretions. Okay. Other neurological signs are obviously the different type of memory deficits, whether that's a change in level of consciousness or a forgetful short-term memory loss, long-term memory loss. And then also signs would be those post-traumatic seizures. And then some of the residual effects that can happen, or the patient is uninhibited, they have aggressive behaviors, they're impulsive, their emotions are kind of all over the place. That can happen with residual effects, and those are neurosigns. So on a sensory exam, you're going to start with light touch and work to knock the stimuli if there's no reaction. Obviously, you do sharp versus dull for senses. And then your cerebral exam, things like finger to nose, limb ataxia, are they able to respond to those type of cues? And then what do your reflexes show you? What are hyper and hypo reflexes indicate? The spinal cord injury. Okay. So this patient, up on admission, the emergency room, her heart rate's 120, blood pressure is 98/50, respiratory rate is 32, temperature is 97.7, SpO2 is 92, and she's on rebreather mask. The primary survey or assessment reveals that the patient's airway with no signs of current obstruction. The breathing is tachypnic and regular with increased effort displayed with accessory muscles, circulation with tachycardia and mild hypotension, positive 1 distal pulses bilaterally, and the skin is warm and dry. ECG reveals atrial fibrillation with ventricular rate of 132, ST depression, and anterior lateral leads. Okay, so in your physical exam on this patient that we talked about that we got the report on the last time, she does have a hematoma on her head, but she does not have a laceration, and there's no drainage noted. So the neck, she's unable to state pain, but she does grimace whenever you palpate that area. She has no overt signs of trauma. She has irregular rate and irregular rhythm, with no extra heart sounds. Her pulses are brisk. Brisk capillary refill, her pulses are +1. She has fine crackles at the base, bilateral of her lungs, and increased work of breathing. Her GI is soft, non-tender, non-distended, and she has active bowel sounds. GU shows no sign of trauma or discharge or lesions are present. She also did her skin. She has ecchymosis on limbs with no open wounds. Neurologically, her eyes are open to noxious stimuli. She has no verbal response and withdraws to pain in the upper extremities and flexes with the pain in the lower extremities. Her pupils are brisk and they're equal for corneal reflex, and VOR intact. Grimace to pain is equal and bilaterally. Gag is intact also. Motor, she withdraws to upper and lower extremities. Sensory, she responds to painful stimuli in all 4 extremities. Cerebellum, she's unable to cooperate with the exam. So she can't do those things, like I just talked about, the touching the nose to the face, those type of commands that you want her to do. Her reflexes are normal in all extremities. They're not hypo or hyper. So what's your score for her? After everything we just went over, what's your score? So her eyes are open to noxious stimuli only. She has no verbal response, withdraws for pain in the upper extremities, and flexes to pain in the lower extremities. Good job. It is 7. And so she got 2 points for eye opening to pain. She got 1 point for no verbal response. And she got 4 points for withdrawal to noxious stimuli. So what is the coma? Where does she fall in at? What did we talk about our levels were? We talked about extensive or severe brain injuries between and what? 3 and 8. That's right. She's severe. See, y'all are learning something today. Okay, based on which finding, objective finding, which statement is false regarding this patient? The patient's rapid atrial fibrillation could be exacerbated by hypokalemia. The patient is showing no signs of heart failure exacerbation. The patient is showing signs of cardiac ischemia. The patient's respiratory status is compromised. Which one is false? What about B is telling you that it's false? What are the signs she would need to be showing for heart failure? What makes that sentence false? B is right. What makes it false? Oh, but Rebecca, that's okay. Sometimes people are just like, "Can you ask that again?" And I realize sometimes when I ask a question, it doesn't make sense because I'm trying to make it up into a question form. Okay, so what I was looking for on some of this is, so B is the wrong answer. It's false that she's not showing signs, but she is because she has fine crackles on auscultation, hypotension with weak pulses, revealing that the left ventricle is unable to effectively pump the blood, the current blood volume. Okay. After assessment is completed, the patient develops generalized convulsive activity. Concern for a general tonic-clonic seizure. The provider orders 4 milligrams of razepam. The patient's airway is at risk during the seizure, and the patient emergently intubated by the provider. Because the seizure activity is not completely ceased by the initial medications, a propofol infusion is started. Visible seizures activity cease after initiation. A CT scan is ordered by the provider to assess the type of injury sustained in the motor vehicle crash. Different advanced neurological monitoring modalities are being considered. So the CT scan, it's good for some things. It shows the structure, and it's very good at identifying the hemorrhage. So you can be able to tell the area of the hemorrhage, and it's pretty accurate in the size of the hemorrhage. But what it doesn't show is any ischemia or any anoxic area. They're very quickly able to obtain, and it doesn't expose the patient to radiation. And they can also identify any type of bony injury. The CT angiogram, this is done with contrast. It can identify thrombosis in a major vessel, any vascular formations like an aneurysm. The spot sign, the contrast will show the hematoma showing the active bleed And this is done with an iodinated contrast, which can cause an allergy reaction and kidney injury. There's some patients that this would not be okay for. The patients that have any type of shellfish allergy and kidney injury, why wouldn't this be good for a patient with kidney injury? Yeah, so the kidney would have to be able to filter and process that dye, and it would not be able to do it. Too much work on an injured kidney. Okay. Then we have the ICP monitoring, and we're not getting too far into this. On ICP monitoring, it uses a device, and I'm going to break them down in just a minute, but it uses a device that's able to sense the pressure inside the skull, and it's recorded, and they follow it and track it. On an intraventricular, is usually the most accurate monitoring method for ICP. This catheter is inserted into the intraventricular area. A hole is drilled through the skull, goes in, and this is the area of the brain that contains the CSF. It can also be used to drain fluid out of the catheter. The drawback to this is when the intracranial pressure is very high, it's hard to get the catheter in place. It's basically almost kind of pushed out by the pressure in the head, or in that section of the brain. Intraparamechial is a test measurement the pressure in the head directly by using a small pressure sensitive probe that is inserted through the skull. So one's a probe, one's a catheter. This is inserted directly in the head, but the other one is drilled and you go right into the lateral ventricle. The transcranial cerebral, yes, it's not in the lateral ventricle though. Transcranial cerebral oximeter, and the intraventricular is the most common one. It's what I see in the hospital, and I think it's the most common around everywhere. The transcranial cerebral oximetry, it does the exact thing as any other oximetry does. It just depends on the placement. It's applied in the critical care setting. It detects cerebral hypoxia. There are a lot of different ways this is done. It's done with the light, just like on the pulse ox. And there's many different brands. There's also ones that will do cerebral blood flow monitoring, and it's kind of done the same way. They're both non-invasive. It's measuring the cerebral oxygen saturation. It uses that spectrology, which is the red light. And then you have the continuous EEG, which, what does that tell us? Yeah, so the EEG tells you about the brain activity, the waves, detects seizures, the electrical activity of the brain. That's right. Okay. So with advanced monitoring, the CT scan on this patient is completed, and the patient has been accepted to the neuro ICU. The patient is brought up to the ICU, and handoff care is given at the bedside by the emergency room nurses and the ICU nurses. The radiology reports a right frontal interpractical hemorrhage with IPH with posterior occipital contusion. The cerebral edema and midline shift is seen. The patient is started on hypertonic saline for the edema, and the decision is made with the medical team to place a ventruloscopy for ICP monitoring and a ISF drain. Due to her INR of 3.1, she is reversed prior to placement of the ventruloscopy. After placement of the drain, continuous EEG is placed. So, what is the purpose of implementing the continuous EEG monitoring for this patient after this procedure? So you put it in to monitor their ICP. You drained off the CSF fluid. Why do you want this EEG placed? Okay, so the answer is C. You want to assess for clinical seizures. Because the patient previous seizures, this E is placed to monitor subclinical seizure activity. Propofol infusion can be titrated based upon the EEG results. So you want to be able to follow this patient all the time, especially because of the seizure activity from previously. A lot of times it can be masked. The seizures the outside observations of the seizure can be masked by medications when the activity in the brain can still be happening. The ICRP reported on the monitor has been at 18. While suctioning, the ICP increases to 26 while she's coughing. The ICP returns to 18 within 2 minutes after coughing is complete. What is the best nursing intervention? That's right, it's C. You're going to do nothing because these are normal as long as it returns back to the baseline. Anything that's sustained greater than 5 minutes causes for evaluation and interventions. So now I get to the nursing management. So you got to monitor and protect that airway in non-intubated patients. You monitor for the signs of respiratory failure, hypoxia, hypercarbia, anxiety, restlessness, confusion, airway obstruction, such as tongue swelling. And in any patient who has a Glasgow score of less than 8, you need to provide airway protection for that patient. Remember we said 3 to 8 is severe head trauma. They're definitely at risk for not being able to maintain their airway. So an oral gastric tube to help prevent aspiration also needs to be placed. To maintain adequate oxygenation, you want to keep their SATs greater than 100. The PA2 at 100. You really want to control the pH and the PaCO2, and you want to keep the CO2 35 to 45. You want to avoid the hyperventilation unless there's present signs of herniation, which would be the abnormal posturing, unilateral, bilateral dilation, and non-reflective pupils. And Thomas, this goes back to when you asked me earlier about why would you want to hyperventilate a head trauma patient, and that's if they're seeing signs of herniation, which is it's more advanced than what y'all are learning right now, but there's ways to try to stop the herniation by manipulating the gases and the levels in your body. But you don't have to know that for this section of your learning, okay? So you want to also provide sedation and analgesics as needed. Suctioning, we just talked about, it increases but decreases after cessation of the stimulus is removed. If it doesn't, you need to pre-medicate with a sedative or do an IV push of lidocaine or something like that before the suctioning. You also need to hyperoxygenate pre and post suctioning. So think about that. You're suctioning, you're not just suctioning junk out of their lungs, secretions and that kind of stuff. You're also suctioning air out of their lungs. And the air is oxygen. So you need to make sure you turn their O's up before you oxygenate and then keep them up for a little while after you oxygenate. I mean, after you suction so that they can re-oxygenate themselves. And then limit their time of suctioning to 10 seconds a pass. You guys still with me? Okay. I don't know when y'all are lost. So maintain, well, let me ask this. Did anybody ever answer that they're recording? Just so if people are vigorously taking notes. Okay, I'll find out after. Okay, maintain systolic blood pressure. And why do we want to do this? We want to do this to avoid the hypertension. What do we want to keep the systolic blood pressure at? We said over 100, and that's definitely true for patients. I'm not going to be hard on these numbers. Just know for younger patients, it needs to be 110, and for mid to older patients, it needs to be for mid patients, it needs to be 100, and for younger patients or older patients, it needs to be 110. And then with the systolic pressure, to be about perfusion, you want to maintain adequate urine output, and that's part of your perfused, you're not putting out any urine. No, your systolic pressure being up is help keep that avoid hypotension and allow you to be properly perfused. Peds is not going to be as high as 110, but on this it says 15 to 49. I mean, I'm not going to give you a hard number on that because it depends. Peds, you're talking about from a neonate all the way to a 15-year-old, and that would be specialized to their age. So focus more on this age groups that I've given you. I'm a neonatal nurse practitioner, so we would keep our systolic pressure, I wouldn't want any lower than 60, and that's quite high for a neonatal patient. But again, that kind of gets deep into this, and there's a baseline knowledge that you need to know. I guess I could have told you about myself before I started teaching today. I can do that at the end. Okay, maintain cerebral perfusion pressure. Okay, so what is that cerebral perfusion pressure? It's your MAP minus your ICP. That's what it equals. Target in adults is 60 to 70, but it's dependent on your autoregulation status. Anything greater than 70 with fluid and vasopressors, it may increase respiratory failure. Okay, so you really don't want to see over 70. You want to maintain that hematocrit at 21, hemoglobin at least 7. You're going to adjust your goal for evidence of ischemia and transfuse as appropriate. And why hematocrit? What are we keeping it that high for? Or a minimum of that at? And then hemoglobin. Yeah, it's for your perfusion and your oxygenation. Good. And these are factors that increase ICP. And they're patient factors that increase these ICP. So pain increases ICP. So you need to use some type of analgesic, and you need to add to or titrate as needed. Your seizure activity will increase ICP. So seizure activity has to be treated. Hypotension can lead to, which leads to, which causes cerebral edema. You want to maintain that systolic blood pressure of at least 100 or to 110. And then fever. We go into this whole thing with fever now. So normal temperature, 36.5 to 37.5, which is 97.5 to 98.5. The use of acetaminophen and body cooling devices to keep temperature down. You want to prevent shivering. What does shivering do? Shivering raises the temp. It increases metabolic demand. That's what I was looking for. It increases metabolic demand. It is your body's way of raising the temperature in your body, but shivering also increases metabolic demand. Metabolic demand is bad, and it increases the ICP in your head. Okay, so you need to prevent shivering. Hyperthermia increases metabolic demand, and it may indicate brain stem damage and has a poor prognosis. Anemia you have to monitor for. If they're anemic, this also increases the ICP, and that's because you're trying to get more blood around faster. You have electrolyte imbalances, hypo and hyper. You have hypo and hyperosmolarity. You want to give an osmotic diuretic or hypertonic saline. What does hypertonic saline do? How does it help? Yeah, it draws excess fluid out, which causes what? When you draw fluid out, it decreases edema. There you go. It decreases edema. An osmotic diuretic, it's just what it says. It's a diuretic, but it does not mess with the osmolarity of the system. In fluid overload, you're going to monitor the status. Hypocapnia, you're going to assess your vent settings. And then any of these, I'm not going to read these all to you. You know what they are. They're daily performing, hygiene, noxious stimuli, coughing, straining, and suctioning. We went over. These all increase ICP. Coughing and straining, Valsalva mover, you need to make sure, you know, all those things, they increase intrathoracic pressure and they decrease that venous drainage. So you need to think about laxatives for patients that are problems stooling. You want to eliminate any type of straining. Now, here's your interventions that reduce ICP. Positioning. What's important about positioning? How should they be positioned? Head midline, so they need good body alignment. Need to avoid that extreme. Head rotation needs to be avoided, and hip flexion. What do those things do? They increase ICP, right? Okay, cervical collars, they must fit properly. If cervical collar is too tight, what's it doing? Yes, you're right. It's cutting off and increasing. It's constricting the blood flow into the brain or out of the brain. So it does not allow for adequate circulation. So you have to make sure it's not too tight and that it does fit properly. Head of the bed needs to be positioned at least 3 degrees. Now, everybody's really into cluster care and getting everything done in one time and leaving the patient alone if possible, but that can sometimes be the opposite with a patient with increased ICP. It may need to be drawn out over an amount of time, or some of the care that's not necessary may even need to be delayed until the pressure comes down. Okay, now our medications. So you have mannitol. The dosing's there. It needs to be given rapidly as a bolus. It needs a filter because of crystallization. It's important to avoid that systemic filtration. That affects with the osmolarity. You can have a rebound effect because of the disrupted brain barrier and increasing brain edema. And the rebound effect can be seen after multiple doses, so you have to watch for the rebound effect. So instead of being a diuretic, it would cause it to accumulate more fluid. And why would that be? If your osmolarity is off. Then you have the hypertonic saline. There's multiple examples of the saline concentrations. The same with dextrose. When you get up to the high concentrations, this needs to be given by central line access only. And just for your knowledge, it's 23.4, which is this concentration that has to be given, that and greater has to be given by central line. This increases osmolarity without causing diuresis. And you need to be monitoring your sodium levels every 6 hours. What are we monitoring for? If you are given, if you're now given a hypertonic saline solution, you're going to be monitoring for hypernatremia. Yeah. And then do not increase more than 10 points from the baseline within 24 hours. So if your sodium's 120, don't go past 130 in the first 24 hours. Those type of shifts, big swings in the body, can also cause damage. And they may have a more prolonged effect and less rebound effect than mannitol. The rebound effect of mannitol is the increasing ICP. So it has a less chance of having the rebound effect. Again, this is done because I switched it over to PowerPoint. But So you have your NSAIDs. It should not be given due to platelet function. If you have a bleed, you don't want to be messing with that platelet aggregation. Your opiates that could be given are morphine and fentanyl. You want to be able to titrate these sedatives and provide pre-medication before interventions. That's really important. GABA receptors are your benzodiazepines and your propofol. The infusion syndrome, there's two types of infusion syndrome, and one of them is deflection, so it actually holds on to fluid. And propofol is also used in anesthesia. I don't know if y'all remember, but it's what Michael Jackson used to take to go to sleep at night. And the whole goal of these medications is to reduce the cerebral metabolic demand. Barbiturates like phenobarbital, they're used in uncontrolled ICP. They suppress the neuron activity by decreasing phenobarbital. You'll see used a lot with brain injuries. That cerebral blood flow they decrease, the metabolic rate decreases, and it's helpful with glucose utilization. But cardiac depression, there's a lot of cardiac symptoms. The depression, hypotension can happen with it if it's given in too often with a large amount, hypothermia, and it suppresses your immune system. So management of common complications, hyperglycemia. Why do you think hyperglycemia happens? So these patients with brain injuries can possibly develop diabetes insipidus. Also, the stress from the injury can cause hyperglycemia. And the fluids that you're giving the patient, depending on how much dextrose they have in them, can cause hyperglycemia. So you definitely want to keep your glucose less than 200. You also want to avoid hypoglycemia also. Nutrition and timing of feeding. So this is important. There are two big things with head injury and nutrition. The metabolic changes cause an increase in calorie consumption, and there's an increase in nitrogen excretion. So the nitrogen, your body's healing, it's using up protein. Metabolic changes in that increase in calorie consumption is your body trying to generate more energy to heal. Demand for that protein increases due to the healing and repairing, but it also puts out more ammonia as you're getting rid of that protein and using it up. You want to have this nutritional consult as soon as possible with this patient and the nutritionist. For a patient that's not able to eat, you need to think about parental nutrition via central line or feedings via a nasogastric tube or some type of tube feed. If you're going to insert a feeding tube, it has to go orally if you have CSF, rhinorrhea, or a base of the skull injury. Why? Yeah, it can cause further damage, and if you're leaking CSF fluid, for all you know, you can actually push the feeding tube, because it hits the back of your throat and then goes down, right? Or hits the back of your nose and goes down, depending on which way you're putting it in. So if you have any type of question about a base skull injury, or if you question whether the patient has rhinorrhea, then you need to put it in orally, because you will bypass the nasal cavity and the access to the brain. You want to be able to keep the head of bed elevated to prevent abdominal distension, aspiration, and regurgitation. And the NG tube is also effective because patients that have brain injuries have reduced gastric motility and can sometimes have reverse peristalsis. And those things make that regurgitation and aspiration very common within the first few hours. So with nutrition and time, you feed them as soon as possible. Their calorie consumption and nitrogen excretion are increased. They need that protein for heal and repair. If they're not able to eat, you need to put in a parental nutrition via central line or an NG-OG tube. Head about elevated for distension, regurgitation, and aspiration risk. And nasogastric tube can also be used for gastric motility and reverse peristalsis to help with aspiration within the first few hours. Okay, fluid and electrolyte balance. How does this brain fluid and electrolyte balance? What are the dysfunctions going on there? Well, it could be a metabolic dysfunction and a hormonal dysfunction. Both of those, your hormonal dysfunctions affect with your fluids, as far as holding on to fluids or releasing fluids, and metabolic and hormonal can affect your electrolyte imbalance. So we talked about your labs. I'm going to full set of labs, glucose, and keep up with INOs. That electrolyte imbalance, what are some of those signs and symptoms? How do those patients present? What does that patient look like in the bed to you? Some of the common imbalances, increased lethargy, confusion, even seizures. Yeah, weak. What will dehydration do? They really concentrate your numbers. I use the example as Kool-Aid a lot. You have Kool-Aid, cup of water, and you put more Kool-Aid in it, and those are your electrolytes. But you add more water to that package, and it dilutes it out. Same thing, it dilutes out your electrolytes. You take more water away and really concentrate. Same thing, really concentrate your electrolytes. Irritable, sluggish, tired, weak, all those are right. Okay. So you're going to monitor serum electrolyte levels. It's really important in the patient receiving osmotic diuretics. These patients can also get syndrome of inappropriate antidiuretic hormone secretion. Also have post-traumatic diabetes insipidus. Diabetes insipidus can occur right after the injury. It can last, and then it can resolve, or it can stay depending on the depth of the injury. When the hypothalamus is involved with their brain injury, they have a greater risk of developing diabetes insipidus. Remember, head injuries are usually have effect on sodium regulation in the body. So why is hyponatremia common after head injury? Talked about volume, about fluid volume, but what are some other reasons? What kind of fluid, right, Rachel? What kind of fluid shift? It's extracellular fluid shift. So the fluid shift, extracellular fluid shift, and that affects your electrolytes. Okay, and then how does hyperglycemia play a role in hyponatremia? How does hyperglycemia affect hyponatremia? It can cause an increase in extracellular fluid. So just the same with potassium, how hyperglycemia can push potassium into a cell, hyperglycemia can do sodium. And urine is tested very frequently for acetone. Why is that? What is acetone a form of? Ketones, yeah. So ketones, so it shows how fast and how much your body's breaking down. And if there's acetone in your urine, it can sign a lack of insulin cells. Okay. And then now we're going to get a little bit deeper into fever. So fever, which is pyrexia. Um, when you have a fever, it's a systemic response to a perceived immune threat, whether that's an infection or an injury. Um, and it resets your temperature at a higher level to take care of that. Neurogenics or central fever is a disruption in the brain's hypothalamic, which is the set point. So maintaining this body temperature. What can this fever indicate in a patient with a brain injury? We just talked about there's some type of problem, damage to the hypothalamus, but what else? What about hemorrhage? So this fever in a brain patient or a brain injury patient, it can show damage to the hypothalamus, shows cerebral irritation from a hemorrhage. So that blood that's in there, it irritates the brain, and the brain perceives that as an injury. And then also infection, someone listed infection. So infection, can someone with a brain injury have an infection? Yes. And how early on? Yeah. So there's a lot, of course, there's a lot of causes of infection in a brain injury patient. So it could be from an open cut that happened during their immediately that happened during the actual injury, um, all the way up to it can be a catheter initiated infection. So temperature should be assessed every 2 to 4 hours. And what do you do for temperature is increasing? You need to identify the cause of the injury or it's an infection. So acetaminophen and cooling devices can be used. If you're going to cool a patient, you don't want to induce shivering. We talked about that increased CP. Some of your infectious causes are on here. You have pneumonia, catheter-associated urinary tract infection, and central line infection. You also have your non-infectious causes, which are drug or transfusion reaction, DVTs cause fever, and neurogenic injury. Your pharmacological management of this fever. So your traditional antipyretics, acetaminophen. Now, this depends on, the effect of this depends on having an intact thermoregulation system. So it can work or it cannot work because it needs, in order for this medicine to work, it needs to have the thermoregulation intact. So that would be, it couldn't do it for anything that was non-infectious. So you would have to have this for an infection one. That makes sense? I think I probably could have said that better so you would understand. So acetaminophen won't work on neurogenic injury, but it'll work on pneumonia and all the other infections like that. So you're going to treat the source of infection, which means you remove any unnecessary lines that don't need to be in for extended amount of time. You start appropriate antibiotics. And what do you have to do before you start antibiotic? That's right, culture and sensitivity. And why is that so important? After the first dose of that antibiotic, you're not going to get a true culture. So you won't know to make sure that's effective. So you won't know if you're treating with the right thing. You need that culture so that you can pick the right antibiotic for the right organism. And usually you can cover them for 24 or 36 hours until the culture comes back enough to help them out, and then switch to whatever the culture grows out. But anytime before starting antibiotics, you need a culture and sensitivity. And so you treat the right infection. That's right. Y'all are great today over here on that. And then you have the cooling methods. You can do surface cooling, which is the surface of the skin, tepid sponge bath, ice packs covering the large vessels and axilla and groin regions, cooling blankets, cooling mattresses, cooling wraps. And then they also have on babies. I work in the neonatal ICU. We actually cool down to the core. So we'll put in a temperature probe down their esophagus, and we'll cool them to about 93 degrees. They have to be sedated, and we keep constant EEG monitoring on them. And the same thing's done with adults. Where you can't surface cool them, you have to internally cool them. It's a very advanced cooling method. It causes extensive metabolic complications also, but it's also what's best for the patient. By cooling them, it acts like putting an ice pack on a sprained ankle. Cooling brings down the swelling and edema, and it really helps with the damage that's done by the swelling of the brain in the injured area. And we need to use these devices, all of them, cautiously because we don't want to induce shivering. So seizure prophylaxis. Phenytoin is not recommended in preventing late post seizures, but is recommended for decrease in early post seizures if it's given within 7 days of an injury. And early seizures are not associated with worst outcomes. And you would think that the sooner you had a seizure, the worse your outcome would be, but that's not the case. So it doesn't matter if you have a seizure on day 1 or if you have a seizure on day 10, your outcome is not worse because of that seizure. And it's very important to prevent these post-traumatic seizures. What happens with a seizure? What does it do in your body? And start with brain first. What does a seizure do in your brain? What can it cause? A seizure will cause increased ICP. And if you've ever watched someone have a seizure that's on the monitor, you can watch their O2 sat just plummet while the seizure is going on and come right back up once it's over. But what happens whenever your O2 sat plummets? You have decreased oxygenation. And what do we talk about? What happens when you have decreased oxygenation? Hypoxia. And what does hypoxia cause? Increased ICP. That's right. So seizure is a double-edged sword there. So the seizure itself will cause increased ICP, and the decrease in oxygenation will also cause ICP. And the increase, you're exactly right, the increase in CO2 from the decrease in oxygenation will cause vasodilation, which then starts a whole other cascade. So anti-convulsant medication can also impair their cognitive performance. So if you're doing a neuro assessment on a patient, but they're loaded up on phenobarb, they're not going to give you their best results, I should say. So you need to have the benefit of this med should outweigh the side effects, and that depends person to person. It can also prolong the duration that they're in a rehab type situation, being on an anticonvulsant that basically impairs this cognitive performance, because you don't know whether it is the medicine or whether it is the person. Then we talked about subclinical seizures. They're associated with increased ICP also. You need to look for that subclinical evidence of seizures. And what does that look like? What is the evidence of subclinical seizures? If a patient's just laying there and you can't tell they're having a seizure, well, what if, yes, an EEG, but what if they're not hooked up to EEG? Marissa, vital signs changes. That's what it'll show you, the vital sign changes and eye deviation. Okay, you also have deep vein thrombosis. This is a catch-22 also, as with everything in nursing. So DVTs, you want to give them heparin, but what is heparin going to do? Then the blood, which is going to increase bleeding, right? So for some patients, they can handle the heparin and they will put them on heparin if they're at extremely high risk for developing a DVT. But that is not common, and it does increase the risk for bleeding. It's best to use some type of mechanical, like the compression stockings or the graduated compression stockings that run in the bed. They also, SCDs, that's right. They also help with keeping the circulation going without using the blood thinner. But for a patient that's at extremely high risk, they will still be given heparin and watched very closely. Okay, that's a special patient population. Not everybody is given heparin. So another complication is increasing ICP, and we've talked about a bunch of things that increase that, but the most common cause is cerebral edema. And that edema, it usually peaks between 48 to 72 hours after the injury. We're going to control that by keeping the head of the bed elevated, maintain that neck and head in a neutral alignment, so no twisting or flexing the neck. You're going to initiate measures to prevent the Valsalva maneuver, so stool softeners or laxatives. You need to maintain the body temperature within normal limits. A temperature causes increased metabolic demand, which causes okay. Make sure you keep your O2 in the proper range. Maintain a fluid balance with normal saline solution, and avoid any type of noxious stimuli. So painful procedures during the time they have increased ICP as much as possible. Aggressive suctioning. Pre-medicate with sedation if you need to. Sedation also helps to reduce agitation. And then what do you want to maintain that cerebral perfusion pressure at? Yeah, between 50 and 70, no more than 70. That's kind of pushing the high end of it, but 70, I think your book says 60 to 70, but a lot of stuff that I've also read in your resources says 50 to 70. So no, 50 to 70 is okay. So then you have a decreased cerebral perfusion pressure. And what does that affect? It's just what it says, decreased cerebral perfusion pressure. So that impairs the cerebral perfusion. If you have cerebral perfusion impairment, what do you have? You have brain hypoxia and you have brain ischemia. Well, withholding oxygen and killing brain cells are not good, right? So this can lead to permanent brain damage if it's not corrected immediately. Keep your cerebral perfusion pressure of greater than 50. What happens if this cerebral perfusion pressure falls below the patient's threshold, falls below 50? So if the ICP falls below the patient's threshold, this vasodilation cascade can occur. With the dilation cascade, it causes increase in blood volume inside the brain, which increases ICP. So it's kind of opposite of what y'all are thinking. If the ICP falls, then there's no way to regulate the blood volume going into the brain. So it's just open, just like think of a water hose, I guess, for the lack of a better example. It's just open. So you have this massive vasodilation and increases the blood volume inside the brain, which increases the intracranial pressure. So if the cerebral pressure perfusion falls below 50, you don't have enough pressure in there to keep the perfusion proper. Make sense? And you know that the patient's CPP is at an appropriate level when there's proper vasoconstriction of the cerebral blood vessels, and your ICP is at a normal level. And the ways you keep this cerebral perfusion pressure normal is by elevating the head of the bed. Make sure you have adequate IV fluids or increased IV fluids. IV fluids are going to cause volume, right? Blood volume. If the CPP pressure is too high, you may need to have some CSF drainage. So the elevating the bed, the increasing the IV fluids, and the drainage of the CSF, these all are going to decrease cerebral edema because they increase the venous outflow of blood from the brain. I'll say it again and think about what I just said. Elevating the head of the bed, increasing the IV fluids, and draining the CSF if needed. These all decrease cerebral edema. And they do that by getting venous blood flow out of the brain. Make sense? Okay. We're almost done. We only have a few more slides left. We're going to go over just a little bit, and I apologize. But I want you to be ready. So if you have systemic hypotension, what does this cause? How does hypotension affect your blood vessels? Perfusion, yes, because of vasoconstriction. It makes them constrict, that's right. And whenever you have vasoconstriction, so the hypotension causes the vasoconstriction, and that causes a decrease in CPP. So your cerebral perfusion pressure decreases with constriction. That happens with hypotension. You treat that by increasing your IV fluids and or vasopressors. Preventing injury, this pretty much goes back to first semester, really. Patients that come out of a coma, what are they like? They're usually not with it in their senses. They're lethargic and sometimes followed by agitation. That puts them at a risk for injury. The rest can be caused by multiple things. Their restlessness could be caused by hypoxia, by fever, by pain, even a full bladder in elderly patients. Some restlessness can be seen as beneficial because it helps the lungs and extremities move and they're exercised, but there's a level between restlessness and agitation. You don't want it to go to the agitation part. Agitation can also be caused just from discomfort. It can also be caused by repeat neurological checks. Imagine if someone comes in you and is doing central stimulus pressure on you once every 4 hours. I'd be pretty mad if someone came in my room and was pinching me in the chest every 4 hours. So you have to make sure you do a proper assessment to see if it's because of the injury or because of the actual whatever's going on. What medicine is commonly used for agitated patients and it does not affect the cerebral blood flow or to intracranial pressure? This is one of those questions you need to know for the rest of your life. What medication is commonly used for agitated patients and it does not affect the cerebral blood flow or ICP? benzodiazepines. So Ativan and Versed are frequently used, but they cause prolonged sedation, so it's really difficult to bring them out to do a neurological assessment because the sedation, the life of it is so long. They are used. Just know whenever you get ready to do a neurological assessment, you need to take into account that the patient could be on. And then support family coping. I mean, it's a lot, but give the family accurate, honest information. Make sure that you know their resources for family counseling and group support. You need to determine the family's understanding of the consequences of client's illness. Make sure they understand written and oral instructions for the patient's care. And remember that when family and patients are in this type of environment, whether it's an ICU or just a hospital setting in general, they have an increased anxiety, and increased anxiety affects any person's comprehension of what you're trying to teach them. So reinforcement needs to be done, and that's why you make sure you give oral instructions, but you also send them home or give the patient the written also. And then early education of a head injury patient given to the family should given to the family like that's a pharmacy. The family should focus on enforcing the information about the patient's condition and the prognosis. Have you ever taken care of a patient and you will hear the doctor say one thing and then you hear the parents explain something else when they're explaining what's going on to someone else? They don't understand or they're not comprehending it. So that reinforced information about the patient's condition and the prognosis. Most of these patients are discharged home to a subacute care facility if their brain injury has been severe enough before they go home. The most important part for the family is for you to know the resources and know that you continue to reiterate and reinforce the information that's given. Make sure they're comprehending and make sure they're supportive of the patient. Okay, now I have one more checkpoint, or actually I think I have 3 more checkpoints, and then we're almost done. I'm sorry. I just want you to have it all. I don't know which, I think it's not 86. Which of the following treatments are used for intracranial hypotension? Which of the following treatments are used for intracranial hypertension? Anybody else? Yay, I'm loving all the B's. And that's because the hypertonic decreases cerebral edema, the hypothermia decreases cerebral metabolism, and the mannitol decreases cerebral edema. Okay, that's a good job. Now we have your basic treatment for brain injury should include which one? Yay, look at y'all learning today. That's correct. So your ABCs, your head of bed elevated fever management, and trending neuro assessment is correct. Okay, and then your patient exhibits hypertension, bradycardia, irregular respirations. This patient exhibits which of the following? So, hold on. So hypertension, bradycardia, and irregular respirations. The patient exhibits which of the following? Oh, I'm so happy right now. Yes, that's right. Okay, and then this is the end. Hold on. We wrap up this patient. This 80-year-old female, she was the same one brought to the ICU after a motor vehicle accident. She has a history of atrial fibrillation. She's on warfarin, DM, chronic kidney disease, and has chronic heart failure. Throughout her ICU stay, she has been intubated for respiratory distress, has had increased ICP, has had ICP monitoring placed, managed her intracranial pressure, and an insulin drip to manage her diabetes. She has been stable hemodynamically and neurologically for 24 hours, and it is now time to transfer to the step-down unit. Her functional abilities, both mentally and physically, need to be evaluated at this time, if they have not already, by a physical therapist or an occupational therapist. Throughout the patient's post-acute care, needs will then need to be coordinated with the case management and arrange for the patient's ongoing rehab and recovery. Okay, so that wraps up this patient number 3 that y'all did not kill today. So do you feel like you learned something today? Okay, good. Yes, I will email this PowerPoint. There is encephalopathy that is also on this test. It's not very much that's on this test, and it's not very much that's in the book. I'm going to send out a little handout on that for y'all to look over. And do y'all have any questions? I can't do a review. I don't mind putting together a raising the bar for y'all. Oh yes, Jessica, just make sure you send me the email because I'll forget as soon as I get off here. Immunity is not on test 1. Immunity is on test 2. Test 1 is interpersonal relationships and cognition. Thank you, Rebecca. Thank you. Thank you. Okay, I'll do a raising the bar. I'll do the raising the bar. I'll get it to you. I'll get it to you tomorrow at some point. I possibly can do it tonight, but it'll probably be tomorrow. Okay. Well, I thank y'all. If y'all need anything, did y'all get my phone number at the beginning when I put it in there? Obviously, I respond to email too, but if it's something and you need it immediately, then just text me, and I don't mind getting text at all. Jessica, I believe that's right. I'll have to look at the calendar. I know it's not this coming up Monday, but I'll have to look at the calendar. Okay, please, please, please remember that I'm accessible, that you can reach out to me about anything. Don't wait to the last minute if there's a problem. Joycelyn, the exams are at 1, I believe. I'll confirm that also. Unless you have accommodations. If you have accommodations, then it's a time set up through the testing center. Okay, there's my number. Yes, they're online. What about ExamSoft?
Actually, Lorna, check community because they just posted about it today. So, Ms. Waldock, my question for you is, I know that we had the option to take the exam in person if we wanted to, but I believe Ms. Stevenson